Hello, I'm Dr. Emily Carter, a medical doctor focused on providing thoughtful, evidence based care and supporting patients in achieving better health outcomes. Neuropathy does something that almost no other condition does. It causes burning pain and numbness at the same time. The same nerve that has stopped telling your foot where it is in space is simultaneously sending a signal your brain interprets as fire. That contradiction, too much signal and too little in the same tissue at the same time, is not a malfunction in the usual sense. It is a nerve that has been progressively deprived of what it needs to function normally, oscillating between overreaction and shutdown. Understanding that is the beginning of understanding why specific movement applied correctly can change what medication alone often cannot. Neuropathy in the feet and legs affects tens of millions of people over 60, and the majority of them are managing it with one of two strategies: medication that blunts the signal without addressing the underlying nerve environment, or rest on the assumption that the less demand placed on compromised tissue, the better. Both strategies have their place. Neither one restores what the nerve has lost. The exercises in this video are aimed at something different. These 7 movements come from peripheral neuropathy rehabilitation. Some are standard practice in post-chemotherapy neuropathy recovery programs. Some are drawn from diabetic foot care protocols used across Japanese rehabilitation medicine. None are experimental. All are appropriate for home use by adults managing neuropathic symptoms, provided you are not dealing with active wounds or skin breakdown on the feet, in which case, your physician should be guiding any exercise protocol directly. One movement on this list I want you to hold in mind as we go. Most people and many general practitioners are unaware that nerves themselves need to move, not the joints around them, the nerves. A nerve that has become adhered to the surrounding tissue through inflammation or disuse cannot transmit signals cleanly regardless of how healthy the nerve fiber itself may be. There is a specific mobilization technique used in peripheral neuropathy physical therapy that addresses exactly this, and it is the last thing we will cover today. Tell me in the comments which symptoms are you dealing with: burning, numbness, tingling, or all three? And where are you watching from? I read everyone. Let's get into it. Exercise 1, foot doming. Inside your foot, there are over 20 small muscles. The intrinsic muscle, whose job is not to move your leg or your ankle, but to control the fine architecture of the foot itself. They hold the arch. They stabilize each toe independently, and they create the structural environment that surrounds the nerve endings in the ball of the foot and the toes, the exact location where neuropathic symptoms most often begin. When these muscles atrophy, which happens faster than most people realize, when activity decreases, the nerve endings lose their mechanical support. They become more exposed to pressure and compression with every step. Foot doming is the specific exercise that reactivates this muscle group without placing load through the forefoot, where neuropathic pain is often concentrated. Sit in a chair with your foot flat on the floor. Without curling your toes, try to shorten the foot from heel to ball as though you are trying to draw the ball of the foot toward the heel by lifting the arch. The toes stay relaxed and long. Only the arch moves. Hold for 5 seconds. Release fully, 10 repetitions per foot. It will feel unfamiliar at first, which is precisely the point. These muscles have likely not received a direct activation signal in a long time. The movement becomes cleaner with practice. Building strength in the intrinsic muscles addresses the structural environment of the nerve. What the nerve also needs independently of that structure is sensory input, and that requires a different approach entirely. Exercise 2, sensory stimulation walk. In Japanese diabetic rehabilitation programs, particularly those developed through university hospital networks in Tokyo and Osaka, sensory re-education has been a formal component of neuropathy care for decades. The underlying principle is one that neuroscience supports clearly. Sensory nerve pathways that are not regularly stimulated do not remain at their current level of function. They decline. The nerve endings that have gone quiet from neuropathy will continue going quieter unless the brain receives regular input through them. Input that practice and repetition can, in many cases, partially restore. The sensory stimulation walk uses texture rather than distance. Place a thin towel folded twice on the floor beside a wall or sturdy chair. Stand on it in bare feet, holding the wall lightly for balance, and shift your weight slowly from heel to toe and side to side for 60 seconds. The slight unevenness of the folded towel creates varied pressure across the sole that a flat floor cannot. When this becomes easy, graduate to a textured bath mat, a folded non-slip rug, or as used in Japanese rehabilitation settings, a shallow tray filled with smooth dried beans or rice that the feet press into gently while standing. The goal is not discomfort, it is variety of sensation. Each different texture sends a slightly different signal pattern through the sensory nerves of the foot, maintaining the activity of those pathways in a way that walking on flat surfaces alone does not provide. Sensory stimulation works from the outside in, feeding signals into the nerve from the skin surface. The exercise that follows works from an entirely different direction, and it addresses something most neuropathy patients have never been told their nerves need. Exercise 3, nerve gliding. For most of the history of neuropathy treatment, clinical attention focused almost entirely on the nerve fiber itself. Is it damaged? How severely? Over what length? The surrounding tissue, the fascia, the muscle sheets, the connective structures the nerve passes through on its path, from the spine to the toes, was largely treated as background. Nerves were understood as wiring. Wiring does not need to move. The problem with that model is that nerves do move. With every bend of the knee, every flex of the ankle, every step taken, the sciatic nerve and its branches slide several centimeters through the surrounding tissue. A healthy nerve glides freely. A nerve surrounded by inflammation, scar tissue, or prolonged compression from disuse becomes adhered, tethered to the tissue around it. When it is then asked to move, it cannot travel its full range. The tension that results disrupts signal transmission in ways that are distinct from the fiber damage itself and that do not respond to medication targeting the fiber. Nerve gliding, sometimes called neural flossing, is now a standard component of peripheral neuropathy physical therapy for exactly this reason. Sit upright in a chair, straighten one knee until the leg is fully extended in front of you. Then flex your foot so your toes point toward your shin. Hold for 3 seconds. Then simultaneously bend the knee and point the toes away from you. That alternating sequence, leg long, toes up, then knee bent, toes pointed, gently mobilizes the sciatic and tibial nerve through its full path from the lower back to the foot. 10 slow repetitions per side. Never force the range. The sensation should be a mild, tolerable stretch, not sharp pain. This addresses nerve mobility along the full length of the lower limb. What follows targets the smaller joints and vessels of the ankle, and the reason it matters for neuropathy is different from what most people assume. Exercise 4, ankle alphabet. The connection between ankle mobility and neuropathic symptoms is not obvious until you understand the anatomy. The tibial artery, the primary blood supply to the nerve endings in the sole of the foot, runs directly behind the ankle joint. Alongside it, the tibial nerve itself passes through a narrow channel called the tarsal tunnel, which sits just below and behind the inner ankle bone. When ankle mobility decreases, as it reliably does with age and reduced activity, the circulation through that channel slows, the nerve's oxygen supply diminishes, and symptoms in the foot intensify. Physical therapists working in diabetic neuropathy clinics have observed this relationship consistently. Patients with poor ankle range of motion almost always report more severe foot symptoms than those who have maintained ankle mobility independent of their blood sugar control. The ankle alphabet is the most comprehensive way to move the ankle through its full range without placing any load through the foot at all. Sit in a chair with one foot lifted slightly off the floor, using only your ankle, not your leg or your knee. Trace each letter of the alphabet in the air with your big toe. Write slowly and deliberately, making each letter as large as you comfortably can. Larger letters mean greater range of motion, which means more circulation through the tarsal tunnel with each movement, one full alphabet per foot once daily. The ankle alphabet improves the circulatory environment the nerve lives in. What follows works directly on the nerve endings themselves, but through a mechanism distinct from sensory stimulation. Exercise 5, towel scrunches and marble pickups. Earlier in this list, Footming activated the intrinsic muscles of the foot, isometrically holding the arch up, without the toes moving specifically to rebuild the structural support around the nerve environment. This exercise works the same muscle group through an entirely different mechanism and targets something foot doming cannot reach. When the toes grip and release, scrunching a towel beneath them or picking up a marble from the floor, the nerve endings in the toe pads and the ball of the foot receive direct mechanical stimulation through pressure and movement. This is not structural support. It is sensory activation at the nerve ending itself. The gripping motion compresses the digital nerves running along each toe, and the release allows them to decompress, repeated rhythmically. This creates a stimulation pattern that maintains the activity of the small fiber nerves responsible for fine touch sensation, the exact fibers that neuropathy typically damages. First, place a small hand towel flat on the floor. Using only your toes, scrunch it toward you, then smooth it back out. 10 repetitions per foot. For a more targeted version, place 5 marbles on the floor beside a cup and pick them up one at a time using only your toes, dropping each into the cup. Both variations are used in sensory rehabilitation programs. The marble pickup is more demanding and more specific. Each marble requires individual toe control, which recruits more of the intrinsic muscle group and stimulates a wider range of nerve endings simultaneously. Restoring sensory function at the nerve ending is one goal. Preserving the brain's ability to use that sensory information for balance is a separate challenge, and one that neuropathy attacks in its own particular way. Exercise 6, Proprioceptive Balance Challenge. Proprioception is the sense that tells your brain where your body is in space without you having to look at it. It is why you can walk across a dark room without falling. Your feet are continuously reporting their position, the pressure distribution across the sole, the angle of the ankle, and the brain is adjusting your posture in response without conscious effort. Neuropathy disrupts this system directly. The sensory fibers responsible for proprioception run in the same peripheral nerves that carry pain and temperature signals, and they are damaged by the same processes. What rehabilitation nurses have observed across neuropathy programs is this: patients who continue doing regular balance training after a neuropathy diagnosis maintain independent, confident walking substantially longer than those who stop. Not because the training reverses the nerve damage, it does not. Because it forces the nervous system to work harder with whatever sensory input remains, and that demand preserves the functional use of those pathways in a way that passive rest cannot. Stand beside a wall or countertop with fingertips resting lightly on the surface. Shift your weight entirely onto one foot and hold for 10 seconds. Switch sides. As stability improves, reduce the contact with the surface. Fingertips only, then one finger, then hovering without touching unless needed. The next progression is to perform the same exercise on a folded towel or a slightly uneven surface, which removes the flat floor's predictability and forces the ankle and foot to process more varied sensory information. 2 sets per side daily. Each of the exercises so far has targeted a different layer of the neuropathy problem. The muscle environment, the sensory pathways, the nerve zone mobility, the circulation, the proprioceptive system. The final exercise brings a specific technique to bear on the nerve, where it is most commonly compressed in people with foot neuropathy, and it is the one most people have never encountered. Exercise 7, tibial nerve mobilization at the tarsal tunnel. At the start of this video, I said that most people, including many general practitioners, are unaware that nerves themselves need to move, and that a specific mobilization technique used in peripheral neuropathy, physical therapy, addresses exactly this. I want to be precise now about what that means and why it matters, because there is an important distinction between this exercise and the nerve gliding we covered earlier. The nerve gliding in exercise 3 mobilize the sciatic and tibial nerve along its full length from the lower back all the way to the foot using the knee and ankle as levers. That is a long-range technique. What it cannot do is address a specific anatomical site where the tibial nerve is particularly vulnerable to compression in people with foot neuropathy. That site is the tarsal tunnel. The tarsal tunnel is a narrow passage on the inner side of the ankle just below and behind the ankle bone. The tibial nerve passes through it on its way into the foot, alongside the tendons and blood vessels that supply the sole. In a healthy ankle with good circulation and regular movement, that passage remains open, and the nerve glides through it freely. In an ankle affected by swelling, inflammation, scar tissue from old injury, or simply the connective tissue thickening that comes with age and reduced activity, the tunnel narrows. The nerve becomes compressed at that single point. And because the nerve branches from that point outward into the entire sole of the foot, compression there produces symptoms across the whole foot: burning, tingling, and numbness in a distribution that is easy to mistake for generalized neuropathy, but is at least in part a local mechanical problem with a local mechanical solution. The tibial nerve mobilization technique applies targeted tension and release directly at the tarsal tunnel by combining ankle and toe positions that move the nerve specifically through that passage. Sit in a chair with one foot resting on the opposite knee so the inner ankle is accessible and visible. Slowly turn the foot inward and downward. The movement is called inversion and plantar flexion, while simultaneously curling the toes downward. Hold that position for 3 seconds. This slackens the tibial nerve on its approach to the tarsal tunnel. Then slowly reverse both movements. Turn the foot outward and upward while pulling the toes back toward the shin. Hold for 3 seconds. This creates gentle tension through the nerve as it passes through the tunnel, mobilizing it against whatever tissue may be restricting its movement. 8 slow repetitions per foot. The sensation should feel like a deep, dull stretch along the inner ankle and into the sole. Stop if you feel sharp shooting pain, which signals you are loading the nerve beyond its current tolerance. Perform this exercise last in your session, after the other movements have already warmed the tissue and improved local circulation. A nerve mobilized in cold, stiff tissue responds less well and is more likely to provoke irritation. 7 exercises, each one addressing a different reason the nerves in your feet and legs are struggling. Foot doming rebuilds the intrinsic muscle structure that surrounds and supports the nerve endings. The sensory stimulation walk feeds varied input into pathways that go quieter without regular use. Nerve gliding restores the mobility of the nerve along its full length through the lower limb. The ankle alphabet maintains circulation through the tarsal tunnel and the tibial artery that feeds the foot. Towel scrunches and marble pickups activate the sensory nerve endings in the toes and ball of the foot directly. The proprioceptive balance challenge preserves the nervous system's ability to use whatever sensory input remains. And tibial nerve mobilization addresses the specific anatomical choke point where the nerve is most commonly compressed. The one place where targeted local work can produce relief that nothing systemic can replicate. Full instructions for each exercise, including repetitions, progressions, and sequencing guidance, are in the description below. Save it. Neuropathy is not a condition that responds to a single intervention. It responds to consistent layered attention to the nerve's environment. And that is exactly what these 7 movements provide. 20 to 30 minutes a day is enough. The cumulative effect maintained over weeks is meaningful. If this video reached you at the right moment, please share it with someone else. It might help. And leave a comment below. Tell me which symptom has been troubling you most and which of these exercises you are going to start with today. I read everyone. Thank you for your time.